Welcome to another video on cardiac morphology and congenital heart disease. This talk is on types of septal defects, ASD, VSD, and atrioventricular septal defects. We will study specimens with atrial septal defect, ventricular septal defect of the perimembranous type, ventricular septal defect with the perimembranous type plus subaortic stenosis, ventricular septal defect that is juxta-arterial type and common arterial trunk. We will also look at ventricular septal defect that has spontaneously closed, and we will look at atrioventricular septal defects, atrioventricular septal defects with partitioned AV valves, atrioventricular septal defect with right ventricular dominant ventricle, and finally, an AV septal defect with tetralogy of Fallot morphology. So first, let's take a look at a normal heart from the anterior aspect. This is the right atrium. And if we open the right atrium, and let's take a look at the atrial septal defect in relation to the atrial septum. So if we pay close attention and come closer here with the camera, we'll see that this is the fossa ovalis. This is the inferior aspect of the atrium. This is where the IVC comes in. And here is the SVC, and this is the superior and inferior limbus of the fossa ovalis. If we pull this tissue and look more inferior and medial, we'll see this is the coronary sinus orifice. And if we look closer, we see a valve-like tissue, this small valve-like tissue, which is the Sebezian valve, and this is the eustachian valve that directs the IVC flow straight through the fossa ovalis to the left atrium during the fetal life. So it separates the IVC from the right atrium. If we look at the atrial septum, we see that in the fossa ovalis, the atrial septum is only one layer. However, the atrial wall above it, you see that there's another layer. So there are two layers in the atrial septum closing the atrial septal defect, and in between them there's interposing fat tissue. And we can prove that if we dissected here between the superior vena cava and the pulmonary vein in what is called the Waterston groove right here, that dissection will open into the limbus of the fossa ovalis right here. So the defect can be localized to the fossa ovalis area right here, and that's the secundant type ASD. Or the septum above it can be malaligned so that there would be a defect superior to that near the SVC, or inferior near the IVC, and that's the sinus venosus SVC type or the sinus venosus IVC type atrial septal defect. Or it can be a coronary sinus defect. This is the coronary sinus right here that courses behind the left atrium, and it is roofed by the left atrium. So there will be a communication or a defect between the coronary sinus wall and the left atrium that causes the left atrial blood flow to go through the coronary sinus from the left atrium to the coronary sinus to the right atrium through the coronary sinus orifice, and that's an atrial septal defect of the coronary sinus type. Note that the defect can take this entire distance in the atrial septum, but there will be some variation sometimes, but there usually is always this distance between the anterior border of the defect and the anterior aspect of the atrial septum. It is in this distance that an umbrella device or device closure of the ASD would be supported to close the defect right around the defect here. Okay, we don't have a lot of specimens that have atrial septal defect since ASD is not frequently a cause of death. But we have one here, a patient with Eisenmenger syndrome that is caused by the atrial septal defect. So as you can see here, we can see the defect very clearly. Let me open this. This here is the coronary sinus orifice. and that's the defect. And this tissue here is remnant of the fossa ovalis, and this border is the defect border, the anterior inferior rims of the defect. Now, if you see, usually the shunt is left to right, but with Eisenmenger, then it reverses, it becomes right to left. The size of the defect, as you see here, is not constant throughout life, as this defect may get bigger towards the anterior rim here and becomes closer to the aorta from this side. If we look here in the back, this is the anterior wall of the aorta. This is where an erosion may occur caused by a closure device. Look at the aorta here. A closure device will be placed in the defect, and this is an area where the discs of the device may cause pressure on the aortic root and cause an erosion and complication on the long term. Okay, so now we're going to move on and look at types of ventricular septal defects. So this is a specimen of a small heart. We're exposing the right atrium here, and we can see the ASD, and here's the ASD, and below it is a large orifice of the coronary sinus right there, and that is caused by the persistence of the left superior vena cava. However, if we look at, which is what's of an interest to us, at the interventricular septum from the right ventricle aspect, this is the septal leaflet, the tricuspid valve. This is the anterior leaflet of the tricuspid valve, and that's the posterior leaflet. And in between them is the anterior papillary muscle. If we look at the septum, it is divided into three areas. The area that is under where the septal attachments of the tricuspid valves is the inlet septum. This is the inlet septum. Now, if we draw a horizontal line from the perimembranous defect, or from the perimembranous septum in that case, horizontally towards the outlet septum, the area underneath it is the trabecular septum right there, and the area above it is the outlet septum. So again, here we are looking at the membranous septum, and if we expose the pulmonary trunk more in this way, let's take a closer look. This is where this is the perimembranous or the membranous septum right there, and this is the most common site of ventricular septal defect, and it's called the membranous septal defect or perimembranous septal defect. Not only the size is important, but also the location of this defect is important, because this is where the conduction system passes through. So for surgical closure purposes, the surgeons need to be extremely careful when closing this defect. This is a closer view, and as you can see, this is what is called the perimembranous septal defect. Now, if we open the pulmonary trunk more, we can see that this defect is separated by the pulmonary artery by this thick muscle band, which is the crista supraventricularis or the infundibulum. And if we look anteriorly, we see this thick muscle trabeculation that is called the trabecular septomarginalis, extending anteriorly from the free wall of the RV, posteriorly into the interventricular septum here through the parietal band. And that's the trabecular septomarginalis. If we flip the heart and look at the left ventricular side and look at the location of the perimembranous VSD, it has a classical location, as a matter of fact, in relation to the aorta. Here we can see the anterior leaflet of the mitral valve, that's it, in relation to the non-coronary cusp of the aortic valve. They are in fibrous continuity, and we can see this. This is the defect right there, and the defect is right between the non-coronary cusp and the right coronary cusp, as you can see here. And through the defect, we can see a remnant of the perimembranous septum. This is where the His bundle for the conduction system passes through, and this is where the surgeon can close the defect. So let's look at this next specimen. Here we can see a ventricular septal defect of the perimembranous type. However, it is much larger than the previous defect in that it extends more to the borders, so it can extend to the inlet septum or to the outlet septum or to the trabecular septum. So in this particular case, we can see that the infundibular septum, which separates the right ventricular outflow tract from the left ventricular outflow tract, right there, is deviated posteriorly. So if we flip, let's look at the left ventricular side here, we can see the defect from this end, and here's the interventricular septum. You can see how it's causing narrowing of the left ventricular outflow tract. Let's take a closer look. So this is the mitral valve right here, and here's the VSD, and here's the narrowed down LVOT, left ventricular outflow tract. See how narrow it is because of the deviation of the ventricular septum right there above it. So that can cause obstruction and further lack of growth to the areas above it, so it can be associated with coarctation of the aorta or even interruption. If we look closely at this area, we can see the bicuspid aortic valve right there. So note the bicuspid aortic valve. And it's a very common association of interrupted aortic arch. In this next specimen, we will look at a different type of a VSD. This is different from the previous perimembranous VSD in that the defect is not separated from this is the defect, as you can see, is right under the pulmonary valve. It is not separated by the pulmonary valve with a infundibulum or the crista supraventricularis. If we bring the heart together, we'll see that it is right underneath the pulmonary valve, and that's why it's called a juxta-arterial or subarterial or subpulmonary VSD. And it is separated by the usual location of the perimembranous defect here with this muscle ridge or muscle band. If we look at it from the left side, also we can see that is different in location from the perimembranous defect, in that this defect is committed to both the pulmonary and the aorta in terms of flow. If we look at the relationship of this defect to the perimembranous septum, this is where the perimembranous septum is. This is the mitral continuity, fibrous continuity, and underneath is the perimembranous septum, and it is separated from the defect by a muscle ridge, which is right here. This is another type of malalignment VSD, where the ventricular septum, outlet ventricular septum, is posteriorly malaligned, causing obstruction of the left ventricular outflow tract. So let's look at it from the left ventricle side. So you can see here how the ascending aorta is hypoplastic. This is the LVOT, the outlet of the LV. This is the VSD right there, and this is the VSD here, and right next to it is the LVOT, and see how it's narrowed, causing hypoplasia of the ascending aorta. This next specimen will show a different type of not only a VSD but also an associated anomaly with the VSD. So we'll look here at the right ventricular septum aspect. This is the tricuspid valve, the septal leaflet, the anterior superior leaflet here. And we can see the VSD that is related or positioned right underneath the arterial trunk. However, the trunk that is associated with it is not a pulmonary artery trunk, but it is a common aortopulmonary trunk. So that is a truncus arteriosus. And you can see here the truncus arteriosus giving rise to the right and left pulmonary arteries, and also gives rise to this coronary artery right here that you can see. So all coronary artery, pulmonary artery branches are arising from the same common trunk overriding the septum through a ventricular septal defect. If we look at it from the left side, we can again see how the ventricular septal defect is right there and how the outlet of the trunk is overriding the septum. This next specimen is another example of common arterial trunk, where we will see the branches of the pulmonary artery. Let's just put the heart and lungs back in normal order, okay, with the labels, and you'll be amazed sometimes how difficult that could be. So if we get this label out of the way, we'll be able to see the normal position of these organs. So here you can see the pulmonary artery, main pulmonary artery, and the left and the right pulmonary artery branches, as you can see. This is the trachea and bronchus. This is the ascending aorta. If we get that out of the way, we can see the main pulmonary artery arising from the common trunk where the aorta is also arising. If we open this common trunk and expose the internal structure, we'll see the orifice of the common or the main pulmonary artery, and this is the coronary artery. And we can see here the ventricular septal defect and the crest of the ventricular septum where the trunk is overriding the septum. Next, let's take a look at a spontaneously closed ventricular septal defect. This is an adult heart, so the heart size is normal for an adult. If we open the right ventricle, and let's take a look at where the location of where a VSD might be. Let's see. So we're here, we're looking at the septal leaflet of the tricuspid valve right here. And this is the anterior leaflet of the tricuspid valve. And in between them, you can see the scar tissue there, that where the perimembranous defect would be. And if you look on the free wall right there, you can also see some scar tissue in opposition to where the scar tissue here is. So you can make the hypothesis that during life there was a shunt hitting that part here on the free wall, causing the fibrosis that later on closed, and we see the remnant of the VSD closure. If we look at the left side, let's look at the location of the VSD. This is the mitral continuity with the non-coronary cusp. This is the left coronary cusp, and this is the right coronary cusp. And underneath the right coronary cusp, you can see a little recession or recess where a VSD was, and you can see how this right coronary cusp is different from the non-coronary cusp in that it is prolapsing into that defect. This is a common complication of a VSD, causing a prolapse of the right coronary cusp due to the continuous flow or jet from the left ventricle to the right ventricle through this defect. However, the defect now is closed, so it is possible for perimembranous defects to close spontaneously throughout life. And this is one example of how it did happen when the patient reached adulthood and the defect is completely closed. Okay, so this is a four-chamber view, a frontal section of the heart showing the four chambers of the heart. So this is the, you can see the atrial septum here. This is the right atrium, right ventricle, and left atrium. And this is tricuspid and mitral valve. This is where the perimembranous septum is, the location of the ventricular septal defect of the perimembranous type. However, sometimes the defect can include not only this part of the septum, but this entire center of the heart, including the mitral and the tricuspid valve, so that both mitral and tricuspid valve are fused together, and that's called the AV septal defect, as we will see in this next specimen, atrioventricular septal defect. So if we look at the AV canal defect from a superior view, we can see in this specimen that this is the right ventricle, and this is the left ventricle, separated by the interventricular septum and communicating through a ventricular septal defect. So are the left atria and the right atria, separated by also an atrial septum with an atrial septal defect. This is superior fusion leaflet between the mitral valve and the tricuspid valve, and this is the inferior common leaflet of the both fused ventricular leaflets. As you can see, this valve is a common AV valve, or common AV septal defect, or common AV canal, another name for it. So if we look at the atrioventricular septal defect from the atrial side, as in the specimen here, let's open this up and let's look at it from the right atrial side. We can see that this is the septal sulcus of the right atrium. Let's pull this heart back a little bit to have better visualization. So this is the fossa ovalis of the right atrium. This is where the IVC comes in. If we pull it back, we'll see the coronary sinus orifice right there, and that's where the atrial septum moves anteriorly, where we have a primum type atrial septal defect. And below it right there in the ventricular side, on the ventricular septum, we see a large defect inferiorly and superiorly, and there's the superior common valve leaflet right there filling this area. Now we can see that this superior leaflet has attachments to the septum, and that can define the Rastelli types A, B, C. An important thing to point out in this specimen is the location of the conduction system. Usually the conduction system passes through the or around the atrioventricular membranous septum right there, that is missing in this case. So in this case, in the AV canal defect, the AV node is located right there. It moves posteriorly, inferiorly, and right there, and that causes the ECG changes that are classical of this case. So this is a Rastelli type A AV canal, where we have a bridging leaflet with septal attachments to the crest. If we turn this heart over and look at the defect from the left side, which is quite different from the right side, we'll first look at, this is the left atrium right there, and if we come closer, we see this is the coronary sinus, and then this is the left ventricle, and this is the bridging leaflet actually that we saw from the right ventricular side. Let's look at the length of the inlet portion of the left ventricle that extend from here to there. So that's the inlet portion, and that's the outlet portion of the left ventricle, and notice the difference in length. So the outlet portion of the left ventricle is longer than the inlet portion, and this is what gives the classical gooseneck appearance. This is the body of the goose, and then the neck of the goose is the left ventricular outflow tract, and the head is the aortic arch. And this is caused by this defect. You can see the AV defect here that is scooped out and occupying this inferior space. Now let's take a look at this different type of atrioventricular septal defect. If we open the heart from the right atrium here, we will see, similar to previous example, this is the, let's pull this out. So that's the fossa ovalis there. And this is the atrial septal defect, the primum type. And this is the anterior bridging leaflet. And if we pay attention, we'll see that it has an extension of a tongue-like tissue communicating with another tongue-like tissue from the inferior bridging leaflet here. So this tongue tissue separates this left ring to the right ring, and actually causing to have two separate rings of the AV valve. So here we do have an atrial communication, but the ventricular communication may be completely absent, like in this particular case. You can see there's no ventricular septal defect here. And that's the type that is called intermediate or partial or incomplete AV canal, depending on the different nomenclature for this defect. Let's look at another unique feature of AV canal. In this specimen, if you look at the left side, we can see that the left AV valve has a cleft right here in the left side AV leaflet. Usually this leaflet is large leaflets, the anterior leaflet of the mitral valve that occupies this whole area right there. But as you can see, this part is missing and there's a cleft right there dividing this leaflet into two. And that's classic or common in atrioventricular septal defects. This is an example of an uneven partitioning of the AV septal defect type. So before looking at the internal arrangement, we notice a large right ventricle from the outside, and here, this is the large right ventricle, and a very small hypoplastic left ventricle. So if we open this heart out, we can see internally this large right ventricle and this right-sided common AV valve mostly committed to that large right ventricle. And we can see the small hypoplastic left ventricle on the other side. So this is an unbalanced AV canal from the right ventricular dominant type. And finally, this is another example of atrioventricular septal defect. If we open the right ventricular side, we can see a common associated lesion with AV canal or AV septal defect. We can see here, this is the common AV valve, and this is the right ventricular outflow tract, and we can see the stenosis caused by this thick muscle infundibulum, and this is the aortic outflow tract. So this is like a tetralogy of Fallot type defect associated with atrioseptal defect, rather than the usual ventricular septal defect that's associated with tetralogy of Fallot. So we thank you for your attention, and we'll see you in the next video.